did the 18, 19-week ultrasounds, found out that he had the cleft, and they sent me to the level 2 ultrasound, and then found out it was not only in his lip, it was also in his palate.
We treat a variety of conditions. The most common is cleft lip and or cleft palate. We also see patients who have craniosynostosis or really any type of craniofacial anomaly. Sometimes these are in the form of syndromes, like, for example, Pierrot-Band sequence, Treacher-Collins syndrome, Goldenhar syndrome. There's 300 plus craniofacial syndromes that we are involved in the management of. The other things that we do besides surgical management include speech therapy services and physical therapy, rehabilitation, and such.
Well, my role as a pediatric neurosurgeon is looking after the brain's development in children who have both positional deformities and a form of an abnormality called synostosis, which is basically early closure of some of the bones in the skull.
My name is Dr. Pat Ricaldi. I'm a medical doctor and a dentist. I work here at St. Joseph's Children's Hospital. I'm the director of the Cleft and Craniofacial Team.
Hi, I'm Dr. Sarah Gaskell. I'm a pediatric neurosurgeon. I work here at St. Joseph's Children's Hospital, and I'm an associate professor with the University of South Florida.
Daniel Plasencia. I'm the medical director for the Children's Hospital and also part of the Craniofacial Team as a general pediatrician.
My name is Andrea Godwin. I'm a speech-language pathologist, and I work here in the hospital as an inpatient therapist, but also coordinate the Craniofacial Team.
St. Joseph's Children's Hospital is different from other hospitals for many, many reasons. First of all, we're a very comprehensive program. Like I said prior, we have 11 disciplines that are represented on the team: audiology, speech therapy, nursing, lactation consultant, ENT, orthodontics, dentist, geneticist, ophthalmologist, craniofacial surgery, psychology. We also have a social worker on our team. Because we have this team environment, we can see the child. Instead of taking the child to 10 different doctor's appointments, they come to one visit, get all their questions answered. The members are communicating directly, so we can be very efficient in our presentation of our treatment plan, and it's a lot easier on the kids. They don't have to feel like there's something wrong with them. They just went to one doctor visit, not 15.
It was nice that it was all together, that I didn't have to go to 10 different offices for different appointments. Of course, I had never dealt with it before or anything about it before. I knew what a cleft was, but not the details of it for sure.
The first questions we always hear are, how is it going to be fixed and who's going to fix it?
What happens is they come to us usually fearful, scared, they're nervous about what's to come. We spend a lot of time educating them and educating their parents. We are very pediatric oriented, so to try to make the whole experience less frightening.
Well, when a child comes to our clinic, the first thing we have to determine is whether they have something that needs surgery, the early closure of the bones, or whether they just have a positional deformity, some flattening on the head because they've been laying on one side, which is very common in our society nowadays.
We do prenatal counseling, so we meet with the family. The entire team tries to help kind of alleviate some of their fears of what's going to happen, what to expect, how to feed their baby, how we take care of them once they're discharged from the hospital, and it really seems to help.
The role of the general pediatrician within the team is to answer some of the common questions that they may have about feeding and how the children are being fed, positioning. Sometimes the amount of the feed, sometimes is the weight that they're gaining in a regular basis. Are they or they're not? And our role is to answer those questions, enhancing whatever they have as general pediatrician, their private pediatrician.
The effects can be profound as far as the changes in their personality. Sometimes we'll see children who come to us and they're very withdrawn and they don't give you eye contact and they don't want to talk to adults, and especially in the high school age range kids, they are very just embarrassed and don't have good self-esteem, and we take them through this process and they just open up I've had one kid in particular who comes to mind who was just getting ready to go off to college, and I did his surgery, and he never said a word to me during his whole preoperative time. He didn't say, I could never get him to speak to me. He came back after the surgery. He had been gone for a few months and came back to visit us. He came in the office and was giving everybody hugs, and he was just a different kid. It was wonderful.
They had sagittal synostosis, which is an early closure of the main suture that goes from the front to the back of the head. And what that resulted in was a very long, narrow skull with the forehead being very bowed out. So we took that patient to surgery, Dr. Ricaldi and I, and we were in surgery for about 2 hours. And essentially what we did was we removed the fused bone, and then we took other parts of the skull out, and we reformatted the skull essentially so that it had a normal round shape. What we're doing is protecting the brain from future problems, because there's a certain percentage of these children that will develop high pressure in their brain over time if they're not treated surgically. So by doing the operation early, we usually will do the operation, depending on which bone is closed, somewhere between 3 and 8 months of age, so that as the child's brain develops, as it does so much in the first 2 years of life, it is protected.
A very, very fearful mother, mostly. She needed a lot of communication. We did a lot of emailing. We met with them with the team various times. We talked on the phone a lot, put her in touch with families, and everything turned out just fine, of course, and he's doing very well now. A cute little boy. He's had his lip repaired and everything, and she is now one of those parent advocates that is, willing to give her number out. She's glad to talk to other families. She just really powered through all of those fears and did a wonderful job. Her little boy is doing very well, and she's a great advocate for our team and for other patients.
I have such a passion for this. I absolutely love what I do. Sometimes it's embarrassing that I get paid for doing this. It's so much fun. I'm driven by the response from the families. I'm driven by the response from the kids, and it's just so worthwhile.